Welcome to this clinical walkthrough on the chickenpox case for UK-MLA, brought to you by Mediate, your 24/7 practice partner.
All right, let's break down this OSCE station. We're going to walk through 6 key steps, from the moment you say hello, all the way to how you safely close the consultation.
So, first up, your introduction. Those first few moments are so important. You need to introduce yourself clearly, confirm who you're speaking with, and start building that connection with the parent. It really sets the tone for everything that follows.
Okay, so the parent is going to come in with their main concern, something pretty direct like this. And this is your cue to show empathy right from the start.
A response like this is perfect. You're showing you care, and you're using a great open-ended question. This invites the parent to tell you the story in their own words, and it's a fantastic way to kick off your history-taking.
Right, now that you've built that initial rapport, it's time to dive into a focused history. This is where you put on your detective hat and start gathering all the clues.
This right here is the classic story of a chickenpox rash, and it's a huge diagnostic clue. You need to ask about this specific evolution. Did it start with red spots, then turn into those little fluid-filled blisters, and are they now starting to scab over? Getting this timeline is a massive win.
These are your bread and butter questions. You're trying to build a complete picture. You need to know when it started, about any fever, and definitely check on their fluid intake. And a couple of key questions: any contact with other kids with chickenpox, and have they had the vaccine? Every answer helps you piece it all together.
And don't forget to quickly run through the PMFTOSF framework. Past medical history, meds, allergies, you know the drill. It's a great way to make sure you haven't missed anything important, and it shows the examiner that you're systematic and thorough.
This is absolutely essential for scoring top marks in communication. You have to ask about the parent's ideas, concerns, and expectations, what we call ICE. What do they think is going on? What's worrying them the most? And what are they hoping you can do for them today? Addressing these directly shows excellent, patient-centered care.
Okay, moving on. Next, you need to actively hunt for any red flags, any warning signs of something more serious, and then perform your physical examination.
You have to ask about these systematically. Don't be shy. Ask direct questions like, have you noticed any difficulty with their breathing? Or, do any of the spots look particularly red, angry, or like they're filled with pus? This is a non-negotiable step for patient safety.
After getting consent, you'll examine the child. This is what you'll likely see. You need to verbalize your findings clearly to the examiner. Something like, on examination, I can see scattered vesicles on a red base, with some lesions already crusted over. I don't see any signs of a secondary bacterial infection.
Okay, you've got your history, you've done your exam, now it's time to put it all together, give the diagnosis, and explain it to the parent in a way they can actually understand.
Deliver your diagnosis with confidence. And see how this phrase links it all together? It tells the parent you've based your conclusion on their story and your findings. It's a great way to structure it.
It's good practice to give the proper medical term and explain what causes it. It adds a layer of professionalism and gives the parent the correct terminology.
Now translate that into plain English. Explain what it is, what to expect, that it spreads easily, and most importantly, offer that reassurance. Tell them that most children bounce back just fine.
Explaining a diagnosis with clarity and empathy is a real skill. Remember, you can practice this exact case right now. Get objective feedback on mymediate.com.
Let's talk management. A clear, structured plan is how you demonstrate your competence and give the parent real, actionable advice.
Start with the basics. Paracetamol for the fever and any discomfort. Stress how important it is to keep them hydrated, even with small, frequent sips, and of course, lots of rest. Now this is absolutely critical. You must warn them not to use ibuprofen due to the risk of severe skin reactions and not to use aspirin because of the risk of Ray's syndrome. You have to say this.
The itch is often the most miserable part of chickenpox. So give the parent a whole toolkit of things they can do. Calamine lotion, maybe an antihistamine if it's appropriate for their age. Loose cotton clothes, keeping their nails short. These are simple, practical tips that can make a huge difference.
You must cover infection control. Be super clear about how long the child is contagious, until every single blister has scabbed over. That means staying home from school or nursery. And tell them who's most at risk: pregnant women, brand new babies, and anyone with a weakened immune system.
We're in the home stretch. The final part is closing the consultation properly with clear safety netting advice.
Your safety netting advice has to be specific, no vague instructions. Give them a clear list of warning signs that mean they need to seek help immediately. Things like trouble breathing, a very high fever that isn't coming down with paracetamol, signs of skin infection, or if the child becomes unusually sleepy or confused. This empowers the parent and keeps the child safe.
And that's our complete walkthrough of the pediatric chickenpox case. Now, the most important step is to actually put this all into practice. You can practice this exact case now on mymediate.com.